Let's start with a scenario. A 45-year-old woman, no psychiatric history whatsoever, suddenly becomes convinced her family has been replaced by imposters. So is this a very late-onset schizophrenia? Or could this be something else entirely? Something like an autoimmune attack on her brain? In this explainer, we're going to build a solid framework to navigate this exact kind of critical diagnostic challenge, making sure we always think about the brain before we jump to the mind.
So, how do we even begin to tackle this? Is what we're seeing a primary psychiatric illness, or is the psychosis actually a symptom? A distress signal from a hidden medical or neurological disease. Getting this wrong can be absolutely devastating, and that is exactly why we need a systematic approach, one that puts patient safety first.
All right, here's our game plan. We'll start with our core philosophy, and then we'll walk through a 4-step clinical process. We're going to gather clues, learn how to spot the red flags, structure our investigation, and finally, use the VINDICATE mnemonic to build a really comprehensive differential diagnosis.
So our guiding principle is what we call the organic first approach. And listen, this is more than just a checklist. It's a fundamental mindset. It means we actively hunt for and rule out treatable medical causes of psychosis before we even think about landing on a psychiatric diagnosis. Think of it as a crucial safety net to prevent a catastrophic misdiagnosis.
Okay, step 1. This is where we put on our detective hats. It is all about meticulous detective work. We're gathering every clue we can from a detailed history and a really thorough clinical examination. This right here is the foundation of our entire investigation, and the clues we find are going to guide every single move we make from here on out.
The timeline. The timeline is your first massive clue. Did this happen hyperacutely, like over a few hours? If so, you should be thinking about a toxic ingestion, a metabolic crisis, or maybe a vascular event like a stroke. Did it unfold over days to weeks, more subacutely? That points you toward an inflammatory, autoimmune, or infectious process. But if the onset was insidious, creeping up over months or even years, well, that's much more typical of a primary psychiatric illness or a neurodegenerative condition.
Next up, let's dissect the symptoms themselves. While auditory hallucinations are pretty common in psychiatric illness, if your patient is describing vivid, visual, tactile, or even olfactory hallucinations, smelling things that aren't there, that should set off some alarm bells for an organic cause. Same goes for really bizarre delusions, like Capgras syndrome, that belief that a loved one has been replaced by an identical imposter. That's a huge neurologic clue.
And of course, we have to zoom out and look at the whole clinical picture. Are there systemic symptoms, like a fever or unexplained weight loss? Any new neurologic complaints, headaches, seizures? What about their past medical history? A history of cancer or autoimmune disease is a big deal. And I can't stress this enough. A detailed medication and substance history is absolutely non-negotiable.
Your physical exam really starts the moment you meet the patient. Is there attention all over the place? Is there alertness fluctuating? That's a classic sign of delirium. Next, you have to examine the eyes. Seriously. Are there Kaiser-Fleischer rings, which suggest Wilson's disease? Or papilledema, pointing to high pressure in the brain? The eyes can give you direct, invaluable clues about systemic and neurologic disease.
Movement disorders can also be a goldmine of clues. You have to watch the patient's face and limbs. That slow, flapping tremor of asterixis, it screams metabolic failure. What about sudden, jerky movements, or myoclonus, especially with a rapid decline? You might be looking at Creutzfeldt-Jakob disease. And of course, any focal weakness or change in reflexes points you straight toward a structural lesion.
Okay, let's just pause on this one specific sign for a moment because it is so critical. If you see a young patient, particularly a woman, who comes in with new-onset psychosis and has these involuntary movements of the mouth and face, you must have a high suspicion for anti-NMDA receptor encephalitis. Recognizing this sign can literally be life-saving.
Okay, so now that we've gathered all our data, we can move on to step 2, which is all about pattern recognition. We're going to synthesize our findings to identify the key red flags that scream organic cause and demand a deeper investigation.
This is one of the single most important red flags. Think about it. Primary psychotic illnesses like schizophrenia usually show up in late adolescence or early adulthood. So new onset psychosis in a patient over 40 with zero prior psychiatric history, that should be considered a neurological or medical problem until proven otherwise. Period. And as we've already touched on, the character of the psychosis is so important. The presence of well-formed, complex visual hallucinations is a classic sign of an underlying neurological or medical condition. We're talking about things like delirium, dementia with Lewy bodies, or the effects of certain drugs.
This is what we call a hard sign. Any focal deficit you find on your exam, whether it's weakness in one arm, a facial droop, a change in reflexes on one side, it points directly to a localized problem in the brain, like a stroke or a tumor. It demands immediate neuroimaging. So, if your patient has any of these features, a rapid onset, significant cognitive issues, seizures, or autonomic instability with vital signs all over the place, your suspicion for an organic cause has to be incredibly high. These red flags are your trigger. They tell you it's time to escalate the investigation. Okay, so once you've identified those red flags, what's next? Investigation. But just ordering every test under the sun, a shotgun approach, is inefficient and expensive. We need a logical, tiered pathway to guide our diagnostic testing.
So we use a simple three-tiered approach. Tier 1 is our essential screening labs for pretty much everyone. Tier 2 involves more advanced testing, but only for patients who have those red flags. And Tier 3 includes the highly specialized tests that we save for when we have a very specific diagnosis in mind.
Tier 1 is our baseline. Here we're checking for things like electrolyte imbalances, kidney or liver failure, thyroid disease, B12 and folate deficiencies, common drugs of abuse, and key infections like HIV and syphilis. These tests alone will catch many of the most common organic mimics.
Now, if those red flags are present, we have to proceed to Tier 2. This means we're looking directly at the brain's structure with an MRI, its electrical activity with an EEG, and we're analyzing the cerebrospinal fluid from a lumbar puncture. That last one is absolutely critical for diagnosing infections and autoimmune conditions.
And finally, Tier 3. These tests are not for screening. You order these only when specific clues are pointing you towards a rare diagnosis. So for example, if you suspect Wilson's disease, you'll check copper studies. If you're worried about apparent neoplastic syndrome, you'll order that specific antibody panel.
All right, in our final step, we're going to use the VINDICATE mnemonic to organize our differential diagnosis and systematically run through all the major categories of organic disease.
VINDICATE is like our cognitive checklist. It's a fantastic tool that prevents us from getting tunnel vision and completely missing an entire category of illness. So let's walk through each letter.
First up, V is for vascular. An acute stroke, especially in the right hemisphere or in the limbic areas, can absolutely present with sudden psychosis. You also want to consider something called PRES, posterior reversible encephalopathy syndrome, which can be brought on by severe hypertension. The key clues here are an abrupt onset and known vascular risk factors.
I is for infectious. And let me be clear, central nervous system infections are medical emergencies. Herpes encephalitis, for instance, can be fatal if it's not treated right away with antiviral therapy. The classic triad you want to look for is fever, headache, and altered mental status.
N stands for neoplastic. This bucket includes primary brain tumors causing direct mass effect and also paraneoplastic syndromes, where a cancer somewhere else in the body triggers an autoimmune attack on the brain. A history of malignancy is a massive red flag for a paraneoplastic cause.
D is for degenerative. These conditions typically have that slow, insidious onset over months to years. Dementia with Lewy bodies is a classic example here. It often presents with those prominent visual hallucinations, Parkinsonism, and fluctuations in alertness, usually in an older adult. The second I is for iatrogenic, or intoxication. A meticulous medication and substance history is just essential. Prescribed drugs like corticosteroids can induce psychosis. Illicit substances, especially stimulants, are a super common cause. And don't ever forget withdrawal syndromes like delirium tremens from alcohol withdrawal. C is for congenital. Now, while these are less common, they are so important not to miss. Take Wilson's disease, that disorder of copper metabolism. It can show up in a young adult with symptoms that perfectly mimic schizophrenia or bipolar disorder, sometimes years before any motor signs appear. A is for autoimmune. This is a rapidly expanding and absolutely critical category. Conditions like anti-NMDA receptor encephalitis or lupus cerebritis can present with this bizarre, fluctuating psychosis, a subacute onset paired with movement disorders, seizures, or autonomic instability. Those are your T clues.
T stands for traumatic and toxic. You always have to ask about a history of traumatic brain injury, even if it seems like it was a long time ago.
Also, you have to consider environmental or occupational exposures to toxins, things like lead, mercury, or carbon monoxide, which can cause these insidious neuropsychiatric symptoms.
And finally, E is for endocrine and metabolic. Disorders of the thyroid or adrenal glands, and severe organ failure causing uremia or hepatic encephalopathy, these are really common mimics. The clues are often found right there in the patient's systemic signs and in that Tier 1 lab work we talked about earlier.
So, to wrap it all up, the organic first approach is a systematic framework for evaluating psychosis. By meticulously gathering clues, spotting those red flags, and investigating logically, you build a critical safety net for your patients. You ensure you don't miss a treatable, underlying cause that's affecting the brain.
So I'll leave you with a question to reflect on. The very next time you encounter a patient with new-onset psychosis, how are you going to consciously apply these steps? How will this structured way of thinking change your approach and make sure you can confidently distinguish a problem of the brain from one of the mind?